to join, but they're looking into the issues. So, good afternoon and a very warm welcome to today's NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG Sir, Dr. R.P. Joshi, our senior faculty, directors and team from NIIT and NTI, STO sirs, directors of STDCs, faculty of medical college, district TB officers, medical officer, and all other participants. A very warm welcome to today's clinic. I'm introducing the faculty. I'm Dr. Neeta Singla, Nodal Officer, DRTB Center at NITRD. On my right is Dr. Rupak Singla. He's head of the Department TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She's a senior pulmonologist at NITRD. Our director is trying to join, but he's not able to join due to some technical issues. We'll speak to him once he joins us. Meanwhile, now I request our DDG sir, Dr. R.P. Joshi, to give his introductory remarks. Dr. R.P. Joshi, sir.
Thank you, madam. Good morning, all. On behalf of Central TB Division, I welcome you all to this very, very important academic clinic. See, as we treat patients, we all know that those in the clinical side, we all know that tuberculosis is not very easy to diagnose or treat. Even though we know the bacteria, we know the manifestation, it can have multiple manifestations, and there are a lot of treatment challenges, diagnostic challenges, treatment challenges, side effect challenges. So I really appreciate NITRD and all the faculty who are associated with this difficult to treat clinic for guiding people like us who are in the periphery to correctly diagnose, treat, and also clarify the doubts. So learning in medical sciences, of course, is an ongoing process, and more so in tuberculosis. So I really appreciate this efforts. I know a lot of efforts would have been behind presentation of each case. So I really appreciate all of you, and on behalf of Central TB Division, I really wish to convey my gratitude to all those involved for making this ongoing effort, the difficult to treat clinics, which is being conducted regularly. So I request more and more doctors, colleagues to please take advantage of this difficult to treat clinic, both as a learning exercise and also to clarify their doubt. So wishing you all the best. Thank you all. Over to you, madam.
Thank you so much, sir. Thank you for being there and encouraging us. Thanks a lot. Now, moving on to today's case presentation. In the current series, where the states are being invited for in rotation to share difficult cases from their state echo sessions, giving us all an opportunity to learn from their experiences. In these sessions, we have an expert from the state and a national expert. In today's session, the state of Maharashtra has been invited, and we have Dr. Vijay Chauhan from MSF Mumbai, who will be presenting the case. Dr. Vijay is a pulmonologist and is a medical referent in MSF DRTB project at Mumbai. A very warm welcome, Dr. Vijay. The state expert is Dr. Preeti Meshram. She's professor and head of the department at GGMC and JJ Hospital, Mumbai. She is an active researcher and has several publications in the field of tuberculosis. A warm welcome again, Dr. Meshram. And the national expert is Dr. Alpa Dalal. She is head of the department pulmonology in Jupiter Hospital. She is also the chairperson of DRTB Center at Sivri TB Hospital. She has a vast experience in treating the complicated cases of XDR TB and extrapulmonary TB, and she has more than 27 years of experience. She is also part of the national experts for managing the difficult to treat TB clinic and has been supporting us in solving the difficult cases whenever we refer cases to her. Again, a warm welcome, Dr. Alpa. So moving on, I request Dr. Vijay to present his case.
Yeah, thank you, ma'am. Thank you for the kind introduction. And to begin with, first and foremost, warm regards and a very happy new year to all. Respect to the dignitaries, and thank you for the opportunity. able to see my screen, ma'am?
Yes, we can see Dr. Vijay. Can you put it on the presentation mode?
Yeah, thank you so much. Yeah.
Thank you.
Yeah, ma'am, we'll start with this case, who's a 22-year-old female. She was a nurse by occupation, weighing 42 kg. She had symptoms of cough with expectoration, fever, and weight loss for 4 months. She was diagnosed as drug-resistant tuberculosis in the month of November 2020. Her gene expert was MTB positive, RIF resistance low. Since the sputum smear was negative, LPA could not be done. And sadly, the culture also came out to be negative. So we were not able to do the indirect LPA also. So this patient was started on Bedaquiline based long all oral regimen from 8 November 2020. The reason for starting, directly on long oral regimen was because this patient was nurse by profession. She was working closely with uh, TB patients and also had history of treating drug resistant cases. So we thought it would be better if we treat her with a BDQ based long all oral. And since she was in Mumbai, where we have a high prevalence of FQ resistance, approximately to 46%, so we started her on a Bedaquiline based long all oral regimen. So the regimen was Bedaquiline, and we gave moxifloxacin high dose because we consider that maybe she would be FQ resistance, and so to her on the safer side, we gave her moxi high dose. Linezolid, Clofa, cyclosporine was started. Bedaquiline was continued for 6 months till 20th April 2021. The follow-up cultures, that is the third month, February 21, March 21, April 21, were negative. She responded clinically and radiologically also, and the cultures were negative. April 21, Bedaquiline was stopped after completing 24 weeks. Moxifloxacin high dose, linezolid, Clofa, Cyclo was continued in the continuation phase. The patient improved on the regimen. She had a weight gain of 4 kg in starting regimen, and her follow-up cultures were negative. December 21, the patient started showing clinical and radiological deterioration. In the month of May 2022, the MTB culture came positive. The gene expert was done to see whether there is any amplification of resistance, and gene expert came MT positive, RIF resistance. This time the LPA, we were able to get the LPA because she was smear positive. So the results were CATG present, RQB present, gyrase A mutation 3C was present. June 2022, again the culture was repeated, which was again culture positive. And sadly, this patient was declared then failure of a BDQ-based regimen. So this is just to show the duration of exposure of each drug that she had received. Bedaquiline, she got it for 6 months. Moxifloxacin, she got it for 18 months. Linezolid for 18 months. Clofazimine for 18 months. And cyclosporine for 18 months. I would like to clarify that she was a nurse by profession and her adherence was checked. We asked for adherence and she had adhered to the treatment. When she came to MSF, we got her DST done, and that showed moxifloxacin resistant, linezolid resistant, bedaquiline was sensitive, clofazimine was sensitive. So this patient was diagnosed as XDR TB because she was resistant to both FQ and linezolid from the group A drug. Here we started her on a regimen of imipenem, 1000 milligram BD, amoxicillin and clavulanic, 500 mg, 125 mg BD, bedaquiline, we reintroduced, and since there was a long duration of gap between the initial BDQ course and next, we restarted her with a loading of 400 milligram OD and then continuing on 200 milligram OD alternate day. Delaminid was added because she was fluoroquinolone resistant, Clofa, cyclosporine, and ethionamide. Imipenem infusion was given by a peripherally inserted central catheter, that is the PICC line, and we had the patient was taking the imipenem on ambulatory basis. These were the following culture results that we got. July 22 to when she came to us, she was culture positive. August 22, when she was started on treatment, she was culture positive. September, she turned out to be culture negative. October, negative. November, negative. This patient culture converted after 1 month of the regimen that we gave her. She continues to follow up with us and she's still culture negative and she's doing really radiologically and clinically fine. These are the X-rays just to show you what this story was. This patient came with the history of This was the initial baseline in November 2020. She had infiltrations mostly in the basal zone. Then 1 year follow-up, she seemed to be doing better clinically, but we had faint infiltrates on the right upper lobe, and she was symptomatic then. So the we basically, after starting on a Bedaquiline regimen, and when she came to us with when she came to MSF, when she was declared as Bedaquiline based regimen failure, we see that on the right side there is a cavitative lesion that was formed, which was not there initially. So we started on the regimen, and post 6 months completing the regimen, her cavity has collapsed and she's doing better. This is the thick line that we see. So the reasons for some queries that we had was, we wanted to explore the reasons for failure of Bedaquiline based DRTB regimen. We also wanted to discuss about the amplification of resistance, because initially, because the LP was not available, we were actually in dark as to whether this patient was FQ sensitive or FQ resistance. And since the culture had grown negative, we were not sure whether the linezolid was baseline resistant or sensitive. But since this patient improved on the regimen that was given to her initially, the BDQ based regimen, we think that linezolid was sensitive. And then later on, because this patient was once the most important drug of Bedaquiline was stopped after 24 weeks, there was a selection pressure, and then linezolid resistance was caused. We really do not know BDQ still continues to be susceptible. The other question that we wanted to ask was, can Bedaquiline exposed patients be still treated with Bedaquiline based regimen when there is a relapse or a reinfection? So we also wanted to ask about, what kind of treatment regimens would we be able to provide for previous BDQ based regimen failure cases? Because since we have started giving Bedaquiline in the program for last 3-4 years, we generally now see patients who sadly come as culture positive, but with a history of taking Bedaquiline regimen in the past. So in MSF, we prefer to give imipenem rather than amikacin, because we want to avoid the toxicity of the serious toxicity of ototoxicity that amikacin does. And we agree that it's logistically a little difficult to provide imipenem, but nevertheless, imipenem is bactericidal and works both on the multiplying and as well as the dormant bacilli. So we selected imipenem as the drug because this patient was an XDR, also with linezolid resistance. So to give an effective regimen, anticipating a favorable outcome, we thought it was best to give imipenem, which is a better drug. And so we also would like to know, about thoughts about what would be the duration of imipenem infusion be in such case where there is already an history of BDQ taken in the past. Thank you so much.
Thank you, Dr. Vijay. It was an excellent presentation. We would like to take any questions on the history and the patient, if there is any. Almost 45-50 people have joined after Dr. Vijay, while he was presenting the case. So in very short, I will give you the summary of the case so that everybody is on board. So this is basically a nurse who's 22-year-old, and she's a primary MDR case, and she was put on all oral longer regimen. Initially, she responded to treatment, but then she failed. After almost 1.5 years, she failed, and she developed more. They didn't have the initial LPA. So when they did the LPA again, they found that there was resistance of moxiflox and linezolid. So an ITR is started for this patient along with imipenem, BDQ, delaminate, and other drugs. But now the patient is responding to this treatment. The questions Dr. Vijay has is, what could be the reasons for failure for this patient? What is the status of amplification of resistance in this case? What about BDQ, because patient has already taken BDQ and has failed on BDQ regime? And what should be the duration of imipenem? So those are the queries that Dr. Vijay has. So if there are any questions to Dr. Vijay on the history of this patient, you may please raise your hand and we'll take your question. Yes, sir. A very warm welcome, Dr. Rajendra Prasad, sir. Sir, you have a question? Sir, you are muted. Sir, we cannot hear you. You are still muted, sir. Sir, we are trying to yes, sir. Now you are unmuted.
Okay.
Sorry, sir. Thank you, sir.
I'm sorry, I joined little late, and so I could not hear whole of the history. What was the age of the patient, by the way?
22-year-old. 22 years, sir.
22-year-old. Has there been any diabetes in the family or in her?
No, sir. No comorbidities.
No comorbidity. And this was her first treatment when you started with Bedaquiline and based regimen?
Actually, sir, this patient was treated in the program settings during the first episode. She came to us after she failed the regimen that she got, BDQ-based regimen that she got.
So the first regimen prescribed to her was long oral regimen.
Yes.
If I
Yes.
heard correctly, right?
Yes, yes, sir.
Okay, okay. And this regimen was started based on which tests?
Sir, Gene Expert was the only test that was available, which was
Gene Expert was the only test which was available. No LPA was done.
No, because the smear had come negative.
Right.
So direct LPA was not able to be done, and culture also, she sadly turned out to be negative, no growth. So LPA could not be done.
Oh, okay, okay, go ahead. That was my query, because lesion, what I have seen in the X-ray, lesion has started from lower zone initially, and then it has in the next episode it has gone to the upper zone, and there was a cavitating lesion. So ideally, in such cases, because she's a nurse, so she's chances of getting exposure is very high.
Yes.
With all sorts of patients, and she belonged to Mumbai or some other place.
Mumbai, sir, Mumbai.
Acha, Mumbai. Okay, okay, go ahead. Thank you. Thank you, Vijay, for the information.
Thank you.
Any other questions?
There was a question on the chat box. I've seen that whether linezolid was reduced to 300 milligram after 6 months, and why was ethambutol and pyrazinamide not considered for constituting the regimen?
Hello. Did you be so bad? Hello.
Yes, sir.
Hey, I want to know that this patient.
मेरा पेन तो एक कोई है, कौन है? नमस्ते।
HIV status.
Negative.
Sorry to interrupt, sir. Your voice is breaking. Maybe you can put your question in the chat box and we'll take it. Your voice is breaking. Are there any other questions that we can take? Okay. Dr. Vijay, would you like to take the question on linezolid, or we discuss it with the expert?
Yeah, ma'am. Yeah. Ma'am, if you, I mean, it would be better if you take up the case question about pyrazinamide. Yeah.
Sure. We will take it up. So if there are no other questions, if there are any questions, we'll again take them. Now I invite our state expert, Dr. Preeti Meshram, who's head of the department, JJ Hospital. Ma'am, could you join us? Dr. Preeti, you have to unmute. No, you are still muted, Dr. Preeti. Yeah, you can unmute yourself now.
Yeah. So I
Yes.
guess one of the things with this case was that I would like to. I mean, we come across a lot of these cases where patients, despite bedaquiline, fail treatment. Linezolid is definitely to be tapered after 6 months because of the side effects. And why ethambutol PZA was not considered, I guess Dr. Vijay Chavan would be able to tell us that maybe she was a healthcare worker and, you know, we know that ethambutol is not such a great bactericidal drug, though we could still consider Z. The other thing is in Mumbai, the incidence of resistance to Z is very high, almost as in our setup, at least it is very high. It's almost as high as 30 to 35% in the studies that we have done. The other thing that with this kind of regimen that I've seen, especially we are getting a lot of BDQ failures. What we see is all oral empirical BDQ based regimen contains levofloxacin or any fluoroquinolones. For any BDQ regimen to be successful, we need to have a good antibacterial or a good sterilizing agent, because BDQ to reach steady state concentration itself takes almost 2 weeks. So for that period of time, we have patients who are technically on maybe a fluoroquinolone, cyclo, clofa, linezolid, out of which we know cyclo is not a great drug. So clofa is also a in-between drugs. So technically the good drugs that the patient is on is fluoroquinolone and linezolid, out of which if we in Mumbai have a very high resistance, as high as more than 46%, more than 40%. So the patient is technically on a single drug for those 15 days, okay? So I think the regimen somewhere we need to redesign it. We need to include a better bactericidal drug. So what happens now, what we are doing is if we get FQ resistance, we are adding delaminid. Delaminid again takes 2 weeks to reach a steady state concentration. So it is very similar to bedaquiline. So bedaquiline and delaminid are two drugs which will not be very effective for the first 15 days. Then we have an empirical regimen where we do not know whether the FQ is sensitive or no. So we are practically left with 3-week drugs, which linezolid is definitely a good drug. But what happened in this case was something like this, which led to amplification of the linezolid resistance when she actually came sputum positive. So I think with bedaquiline, and especially in Mumbai with the high resistance of FQ, we need to redesign our regimen. Dr. Vijay really used a good, when he had to restart the patient, he used meropenem, which was a better drug, but it becomes very difficult practically to start a patient on meropenem, keep the PIC line, to look after the PIC line, to procure the drugs. So I think a still better option would be still to go with the aminoglycoside. I mean, though considering the toxicity. But this is what I felt after, you know, looking at this case in general.
Yeah, thank you, Dr. Preeti. I think there is a question from STDC West Bengal.
Good morning. Am I audible?
Yes, you are audible.
Actually, the patient has 2 episodes, but in first episode and also in the second episode, the status of pyrazinamide is unknown. Means I missed that. Maybe I have missed that because pyrazinamide is one of the drugs which actually kills the persisters. Okay, so it is inevitable that whatever drug you can administer, ultimately it could emerge resistance. But I will be happy to see the status of the pyrazinamide in either episode. What is the status? Because that might, because the bacilli, the persister might come even as a third episode also in this patient.
Yeah, thank you. So I think there is a question on the status of pyrazinamide asked by 2 participants. Dr. Singla, would you like to add to
Yeah,
this?
just I'd like to make a small comment before we go for the deeper discussion. Regarding, you see, in Mumbai, suppose like cases like this, who only have rifampicin resistance demonstrated by the gene expert, the LP or the culture is not available. So one option is that you consider it could be levofloxacin resistance because the high level of resistance in Mumbai, and start the patient on oral longer regimen with high dose MOX. And second is, no, you feel that even high dose moxi could be resistance and give it elaminate. So I think as of now, better choice will be to start on high dose moxi, thinking that the levo may be resistant and high dose moxi may be sensitive, because we do not have data in such cases. Because then otherwise every case of RIF resistance in Mumbai will be on BDQ plus delaminate containing regimen. So that's one clarification I wanted to make at this stage. I'll come back again once we have more discussion on this case. Thank you.
Uh, Thank you, Dr. Singla. So, any questions on the history of this patient? Are there any questions? So we don't have any questions on the chat also.
Yeah,
Dr.
hi. Yeah,
Dr.
one question for Dr. Vijay. Yeah, sorry, madam.
Yeah.
One question for Dr. Vijay is why we did not do a bronchoscopy when we had initial smear that was negative or a culture that was negative. I mean, we could have then got a DST in the initial pattern.
Yeah, since this patient was like, this the initial part of the history is a retrospective one, which we at MSF did not have major role to play in initially. But since the patient was started on a moxifloxacin regimen and the patient showed that the 3rd month culture was negative, so we did not intend to do an invasive procedure in her, because the patient had responded well. There was a radiological and clinical improvement. So we did not think that, that we need to, if the patient would have been failing or not doing well, then definitely we would have liked to go ahead and do a BAL and try to understand since the regimen was a BDQ based long oral, which included linezolid, high dose moxifloxacin and bedaquiline. So taking that into account and the patient was doing well, we did not think of doing a BAL. Like, it's like, if what was the patient when was referred to us, this was a retrospective one, so we do not know whether the patient, what line of thought the treating physician would have taken. But like, this is what general thing would be, that we would generally not try to do an intervention if the patient is responding well to the treatment that the patient has been given.
Okay.
Yeah, thank you. I mean, you were not involved in the initial part, so I think initially they should have sent. So thank you.
Yeah, but yes, can I just add something?
Sure, Dr. Alpa. Welcome, Dr. Alpa.
Yeah, so a very relevant question Dr. Preeti has raised, and as we are, this is kind of an educating platform. It's an important message also that sometimes, especially in healthcare workers, where we suspect the incidence of primary drug resistance, when more number of drugs being resistant would be higher, it would be a good option to consider at the outset to have an invasive test. But provided it's available in the programmatic setting, it's available everywhere. But having an upfront DST would have been helpful in this condition, in this case, because so this patient was otherwise lucky that she didn't have extensive lung involvement. But it's not uncommon for us to see patients coming up with extensive extensive lung damage, and that too if it comes after a few months and is missed. And then it becomes very challenging to treat these cases.
Okay, thank you, Dr. Alpa. We have a question from Dr. Shreyas and then from STDC West Bengal. Yes, Dr. Shreyas.
Good afternoon, everyone. I'm working at a DRTB center in Kalyan and Ulhasnagar, which is in the Peri-Mumbai region. And I have a question for Alpa Madam as well as Dr. Preeti Madam. When we are considering that the background resistance for fluoroquinolones is very high in Mumbai, sometimes there is a discord between the LPA report as well as the LCDST report when it comes to fluoroquinolone. We have seen there are so many patients with in whom the LPA report would suggest that high-dose moxifloxacin should be effective, but still when we have a Moxi 1.0 liquid culture, it turns out to be resistance, and even the vice versa is true. When we know there is a mu3C, 3D, 3B, where high-dose Moxi should not be effective, in these patients, high-dose Moxi later on the liquid culture turns out to be sensitive. So the decision to start delaminate for these patients, considering them as fluoroquinolone resistant, should it be done at the level of LPA, or should we wait till the liquid culture is available and then make the decision of starting them on delaminate?
Dr. Alpa, are you taking the question?
Yeah. Yes, so yeah, it's a very, very important question. You said that. Suppose this patient on LPA shows that moxi high dose also would be resistant, then of course there's no question, and you would straight away put this patient on delaminate based regimen. Okay? Now the question would be, when this patient has is showing LPA, LPA showing that moxifloxacin might be working based on the mutation, then probably upfront we will definitely not start according to the guidelines. You will not put this patient on delaminate. And when the liquid culture report comes and it shows the discordance, then I would take up, because if there is discordance, it's really currently we don't have enough data to say that no, which one is will be definitely, and then there is a possibility that if there is a discordance, that the resistance might be there. So then it would be advisable to change the patient on delaminate based regimen once the culture report shows a discordance. Also to take into consideration patient's previous exposure, what is the likelihood of primary drug resistance, what is the extent of the disease, what is the general condition of the patient. So based on all these factors, and you need to take a decision. Dr. Singla, would you have any?
Yeah, okay. You see, this is a very much discussed and controversial question. I remember a special meeting was held in the ministry to see what is the level of concordance between LPA and the liquid culture DST, especially in view of the high dose of moxifloxacin being resistant. And it was observed that many cases who were sensitive on LPA were found to be resistant on liquid culture DST, high dose, and the vice versa. The LPA was saying resistance and liquid culture was saying it is sensitive. So first of all, definitely, as Dr. Alpha said, that we should also take into consideration that what has been the background, whether patient has taken these drugs or not earlier, and what has been the response to have taken these drugs, and then how the patient responded. But I feel as of now, as of today, although there are many people who say that LPA reports are as reliable as liquid culture and we should go by it, but the current understanding is that in these cases, the liquid culture DST should be taken as the final one, and keeping in mind the other factors of taken treatment, response to the treatment, one can take a call. Yes, of course, if from the beginning, if you find LPA, the high dose moxi is resistant, then there is no question of using high dose moxi. Go for the next drug in the sequence, that is the delaminate. But whenever the report comes, one has to review the patient again. And in cases where where the LPA shows it is sensitive, but later on the liquid culture DST shows it is resistant, definitely one should take out the high dose moxi from the regimen and shift to the next drug in the sequence. That's what I suggest. Thank you.
Thank you, Dr. Singla. The question from STDC West Bengal.
Am I audible?
Yeah, you are audible.
Actually, I have one statement and one question. Regarding the discrepancy between the second line LPA and the LCDST, my observation is that maybe the patient is infected with heteroresistant strain. So sometimes, so in LPA, you can see the second line resistance, FQ resistance. But when we put the same sample in the liquid culture, it is obvious that the drug resistant strain will grow very slowly compared to drug sensitive strain. So whenever the MITI system will give the audiovisual positivity, maybe that we are getting the growth or colony of the drug sensitive strain. That's why LCDST might show sensitive. So that may be one of the discrepancy causes of between a second line LPA and LCDST. Maybe I am wrong, but I think it might happen. And my another question is that in the first episode, actually only the CBNet was done. So it seems that it was a possibly. So that's why only Gene Expert shows that MTB detected and reef low. I think MTB detected very low. I think that will be the result. So if MTB is low, the reef might be a false resistance, because even in the PMDD guideline, it is written that if MTB is very low, we should repeat the means CBNet twice to confirm the status of the rifampicin, as we have no option of second line, first line LPA by liquid culture, or it means particularly in case of this patient. Thank you.
This case, I think very well said, is whenever a patient has not taken the treatment before, MTB detected very low, I think that was the case in this case, and you have rifampicin resistance detected, then the reliability of rifampicin resistance in MTB very low, especially in primary cases, becomes very, very low. So rather than putting the patient on all or a longer regimen or any other even shorter regimen, always better to repeat the CBNet, reconfirm that this patient is having the RIF resistance, and then only think of the regimen. Because that is a test which can be easily done in the field, gives you result within 1 or 2 days, or theoretically speaking 2 hours, but practically speaking in within 1 or 2 days result is available. Rather than denying the patient drug sensitive treatment and putting the patient on the all or longer regimen. So that should have been done by the peripheral center. And since this PR was negative, later on even the culture was negative, in these cases, before considering all or longer regimen, as already discussed, even we should try to have the increased yield of the sputum positivity by doing the bronchoscopy and bulk. That should be tried in the field condition. That should be the message from this forum. That, and nowadays it is not difficult to link up with colleges or places where bronchoscopy and bulk can be done. So the DTOs and the medical officers in the periphery should make attempts in such cases that they should arrange the bronchoscopy and bulk and then only start the treatment in these cases. Thank you.
Can I add something? Yes.
Yeah, sure, doctor.
So as very rightly pointed out by Dr. Singla, and this was a point was discussed, raised by Dr. Preeti also, that especially because she's coming from Mumbai and she's a healthcare worker. So chances of drug resistance, primary drug resistance would be higher in this case. So just at the beginning, one, because probably she was not able to produce a sputum properly. So HRCT scan chest, just to see the extent of the lesion, whether it's a peripherally placed lesion, and also when you're planning to do a bronchoscopy, you will need to have the exact location from where to do the lavage for this patient. So HRCT scan chest, and followed by that, as Dr. Singla said, that bronchoscopy would have been the right choice, rather than just again depending on her producing a right kind of sputum sample. So that should have been done at the outset. And having said that, in this case, it's less likely to be that scenario, because later on when the culture came positive, I mean, it did show the drug resistance. So if it was not there in the beginning, later on sample showing drug resistance is less likely, unless you consider that she got reinfected with some resistant samples. So in her case, probably she was resistant right in the beginning, but we should have confirmed by doing a HRCT scan test, deciding from which segment to do the lavage, and then go ahead with bronchoscopy and culture.
Yeah, thank you, Dr. Alpha. These were some questions regarding history of the patient and regarding this patient. Now I will be taking the questions which are raised by Dr. Vijay about this case, but I see that another 30-40 people have again joined us in last 15 minutes. So very short history. This is a healthcare worker nurse, a 22-year female who has been put on, who was diagnosed as MDR TB and was put on all oral longer regimen because she's a healthcare worker and maybe she has exposure, and they did not have the LPA report at that time. So initially she responded to treatment, but then she started failing to treatment after 1.5 years of treatment. And when they did the LPA, they got moxi high dose resistance and linezolid resistance. So patient is diagnosed as XDR, and then her treatment was changed and she was put on ITR, starting with bedaquiline, delaminate, and imipimab, along with other drugs. So the questions, and now she's responding to treatment. The questions that Dr. Vijay has raised is, what could be the reasons of failure in this case? What is the status of amplification of resistance? Should we give bedaquiline to somebody who has failed to a bedaquiline containing regime? And what should be the duration of imipinab? So with these questions, now I come to Dr. Preeti Meshram, who's head of the department JJ Hospital, and to Dr. Alpa, who's head of the department Naptune Hospital in Mumbai. So Dr. Preeti, over to you for these questions. Dr. Puri has raised it. Dr. Puri from NITRD. Yes, sir, you have a question?
Dr. Singla, good morning. My simple comment is that the patient, you say that is smear negative, but you have diagnosed as a case of tuberculosis. Now we started with some sputum which was saying that it is a RIF resistance. And to have the total pattern, they are advising the ball should be done in the very beginning. When the sputum is negative, it is usually a paucibacillary, means the infection load is less and resistance is also less. And doing a bronchoscopy in a tuberculosis patient in all cases recommended that in all patients it should be done. How far it is justified that a team of healthcare workers are exposed to a TB patient who is a resistant? It is better that you start with the treatment and you monitor the sputum more frequently. As the old teaching is there, in a case of a smear negative, if you wait, the sputum will become positive in next 2 or 3 weeks. So why you are doing this iatrogenic spread of the resistance bacteria in a bronchoscopy suit? That is my concern.
Okay, I think this was thank you, sir. This was an exception because the patient was a healthcare worker, so it was quite likely that she was exposed to a lot of drug resistant cases. So initially, based on the gene expert, definitely at that time nobody will do a bronchoscopy. But when the follow-up culture, probably when she came smear negative and then we couldn't do a LPA, and then she came culture negative and we could not go ahead with the other tests, because she being a healthcare worker, there is a high chance that she is exposed to a lot of resistant cases. So it should go case by case. We are not advocating that bronchoscopy should be done in each and every patient. It should be taken case by case. So she was a healthcare worker. We know she was in a healthcare setting. As Dr. Vijay said, that she was treating TB patients as well. So maybe when we thought that the cultures were negative, and by that time she also had received a significant amount of her anti-TB drugs. Okay. So that time probably we should have gone ahead and got a bronchoscopy done. Okay? So it's not for all patients. But
my first question is that at the start of the treatment, was the culture put? At the start of the treatment, was the sputum was subjected to the culture? Can you hear me?
So I didn't get your question.
Yeah, Dr. Vijay, could you respond to that question?
At the start of the treatment, was the culture done?
Yes, sir. As per the program, the sample was sent for culture, and that came out to be no growth.
No growth. And then after that, you should subsequently do the culture as per the guidelines.
Yes,
show me the culture which was done on the card subsequently. If the culture is negative, and why are you suspecting high level of resistance and advising ball? That is the main question. Question is that if it is a resistant, it will become positive and then you can do the test. So culture is required only when the bacillary load is there. It should be done in the very beginning, in the initially, and 2 samples should be done if it is negative. First month it should be done. Why it has not been done after 6 weeks when the culture was negative? You should have subjected the sputum to the culture. So we are not following the guidelines. We are not following the standard. We are not looking at the culture report. We are looking at the gene expert. We are looking at the LPA. after 6 weeks, 8 weeks of giving the treatment. So adding another modality will unnecessarily give a wrong message. We are seeing the patient with CT only, no chest X-ray. We are seeing the patient with ball, no sputum examination. And we are seeing the patient with the ball with rifampicin resistance, and then subsequently all sputum negative, and then what to do? So we should not consider that ball is the answer in this case.
Thank you, sir. Dr. Alpha, would you like to add?
Yeah. So yes. So Dr. Puri, I would just like to clarify that the concern that you raised regarding iatrogenic spread of infection, so which is not there, because there are very set protocols now when the bronchoscopy is required for a patient of drug-resistant tuberculosis. So infection control measures are set for taking care of the spread of infection in the room, the use of negative pressure or the use of exhaust fan, shutting off the air conditioner, all that is there. Also, the cleaning protocol for the bronchoscopes are well in place, and most of the institutes are following those protocols and should follow. Now, so that will add the fear of having a iatrogenous spread of the disease. Now, other thing which you have raised, and you said that later on the sputum culture should have been sent once the culture was negative. Now, most often the clinical scenario, so technically or theoretically what we are discussing or what we are suggesting may be good, but when we see practically what happens is, once the patient is put on treatment, there is a response. The cough would reduce, even the bacillary load would come down. And later on, we've lost the chance of getting a sample for doing the culture. And in crucial cases like this, a healthcare worker coming from Mumbai, not having a culture positive, the window of opportunity that we get to get the right kind of sample is in the beginning, especially when the gene expert is showing very low. And that is the reason why doing a CT scan and getting a right kind of sample with bronchoscopy is worthwhile, because otherwise you lose that window. Once the patient becomes sputum negative because of the treatment, this can happen. So that is the reason why we are suggesting not as a routine to do bronchoscopy and BAL for all patients. This also brings us to the first question that Dr. Vijay said, as asked, that why did BDQ failure happen in this case? So patient initially was given the right kind of regimen, but we do not have the resistant pattern, whether she was fluoroquinolone resistant or no. And as per the protocol, after 6 months, we stopped the bedaquiline. So we are left with linezolid, moxifloxacin, cycloserine, and clofazimine. And of that, most likely the fluoroquinolone was resistant. So he's left with only 3 drugs: linezolid, cycloserine, and clofazimine, which is clearly a weak regimen. And this is what we are seeing. This is not uncommon scenario that we see in Mumbai, that initial, because of the bedaquiline, there is a response. There is clinical, radiological, as well as microbiological response. And once you take off the bedaquiline, after a period of 4 to 6 months, when the sustained effect of bedaquiline goes away, the regimen becomes weak and patient has a relapse. So there is definite response, there is culture conversion, and then there is a relapse. Why? Because the regimen become weak. And that is why it is important to have the DSC right at the beginning. Also considering whether these patients can be given bedaquiline extension if you don't have a LP available, or if LP is showing that there is resistance. And that is the reason why in this case bedaquiline has failed. Because what happens is that in the failed condition, picking up the clinical failure becomes very difficult, and that doesn't happen ideally. I mean, when the patients are being followed up, clinical, radiological, and microbiological evaluation has to be done. And before radiological and microbiological failure, the clinical signs are apparent, but they are not picked up. And later on in continuation phase, we are doing culture, which is done 3 monthly and not monthly. So there may be a little bit delay in picking that up, and routinely X-rays are not being done in the follow-ups. So that is the reason why the initial part of the failure was not picked up. And only when she culture converted, this was picked up and this was declared as failure. In the whole process, a lot of time is wasted. And that is the main reason, and also the answer to the first question, that why did bedaquiline failure happen?
I fully agree with you that we should know the DST pattern when we start the bedaquiline. So that's why it is very important that the first sputum is a very important specimen. We should see whether it is culture, the sputum specimen is collected properly or not. Proper sample has gone there. What are the causes of failure? So if a failure of first sputum culture is there, when we are starting the regime, we cannot take any decision whether we should continue with the levofloxacin in the bedaquiline young regime, or we should switch to the moxifloxacin because the CBNet is positive for RIF resistance, LPA is negative, linzolid, clofazimine. These resistance patterns should come up in the front. So if it is a negative, so this should be a red signal that we should immediately take another sample. That's why I'm saying that in the first 3 months, it is not that first sample is done and the patient is seen after 3 months, whether the culture has come negative or positive. So the first step was the evaluation of the culture report. We should evaluate these culture every 3 weeks from the microbiology department should evaluate. The patient is a healthcare worker. It is much more important that we should see the culture properly. That was my point.
Neeta, may I come in?
Sure, sir. Sure.
Actually, just I wanted to know what is the current situation of the patient.
So Dr. Vijay, I don't see offline, but the patient is now much better and responding to treatment. That's what Dr. Vijay has informed.
Yeah. Patient is now responding. Now, listening to Dr. Singla, Dr. Puri, and everybody, one thing was very clear in this case. Although ultimately she turned out to be XDR TB, there is no confusion about it. But still, the culture should be the gold standard to say all this. We have seen many like what I gather from the case, that her gene expert was I think weakly positive or what, and then the rifampicin resistance was there, and in this scenario the sample should have been repeated if it is available before you go on to this. But anyhow, ultimately, see, to my understanding, the treatment has been started very hurriedly in this case. But luckily, she is responding, and you have to be very careful because there might be still. Have you got any culture sensitive DST report, or have you sent any culture DST report?
Yes, sir. We have sent cultures, and we got the culture report as moxifloxacin resistant, linezolid resistance, and that's the time when we started treatment. And after starting imipenem based regimen, she culture converted after 1 month.
Of culture? Now the culture negative.
Yeah. Every month we do cultures, and every month the patient has been culture negative, and she's doing clinically and radiologically better.
Better, okay. Because she started with the lower zone lesions. That is creating little confusion. That is why many people are saying at that time probably bronchoscopy and BAL would have been done and would have shown little more light. So that was the reason. But I agree with Dr. Singla and Dr. Puri's comment. But anyhow, ultimately patient had an XDR TB, and now she's responding the treatment you prescribe. Ultimately, if everything goes well, it's okay. But you have to be careful, and you have to follow this patient very religiously to see what happens in the future. That is my comment.
You see, let me just clarify regarding the role of bronchoscopy. Patient is a healthcare worker. She is in Mumbai where the F2 resistance levels are high, and the sputum, the MTB is very low. So in these cases, of course, first step will be to repeat gene expert.
Yes, I agree with the Rupak. Same statement.
And then even after, suppose the gene expert second is also showing the same thing, MTB very low and the LP is negative. I feel to prescribe the appropriate regimen. You start on some regimen like it was done as high dose moxi, plus you must do some measures to increase the yield of sputum positivity, because ultimately in case by doing the BAL, you are able to have a positive sample or even the positive culture later on, you will have the DST to the other drugs. Like in this case, it looks like retrospectively from the beginning patient was resistant to high dose moxifloxacin. So there was a fall and rise phenomena. In the beginning of 6 months, patient responded. And then after that, gradually the drug resistant bacilli grew and she failed to treatment. So even in this case, we have had culture reports saying that rifampicin resistance, the FQ resistance high dose is resistant or some other drug is also resistant, then from the beginning a different regimen could have been started. Bedaquiline use could have been prolonged. We all miss the opportunity of doing this in the management of the patient. So I think in these cases, the bronchoscopy and BAL should be considered. Thank you.
Thank you, Dr. Singla. STDC West Bengal.
Unmute karo, unmute.
Yes, am I audible?
Yeah.
Actually, all you know, sir, ma'am, that the LOD, load of detection of gene expert is 139. And for LP, it is
ये सभी मैंने उनको दिया भाई
10,000, and for LC, it is 10.
जरा उसको लिख लियो
By
बड़ा
gene
फजीक
expert,
पेशेंट है बहुत ज्यादा रिकॉर्ड है
low,
तो
but by
खाली तुम
LC,
JR3 और
growth. So that means in that sample that was put on LC, there is no viable bacilli, or if that viable bacilli was there, that was less than 10. So I think one point has to be clarified whether as per PMDT guideline, when you do a gene expert, reflexly one sample to be sent to LPA. So whether the sample sent for LPA was done after patient was initiated a treatment, that is a very critical point. Means gene expert done and reflexly one sample will go for LPA. Might be here that it might happen that gene expert was done and patient was put on a treatment and then one sample was sent for LPA. That's why the LC came negative. Thank you, ma'am.
Okay, thank you for your question. Dr. Vijay, if he has any clarification on this, I think that's a 3-year-old history, so he may not be having those details. It's okay, Dr. Vijay. Your point is taken. So now let us go question by question. So I will take each question and then I invite Dr. Preeti, Dr. Alpa and Dr. Singla for this question. What could be the reasons of failure in this patient? That was first question that Dr. Vijay has raised. So Dr. Preeti, your comments on this?
So definitely, as Singla sir pointed out, there was a fall and rise phenomenon because to begin with, it was quite possible that the patient was already probably already had quinolone resistance, and then she was started on a relatively weaker regimen to begin with. She was started on BDQ, quinolone, linezolid, cycloplofa, of which BDQ took 2 weeks to act. Probably quinolone was resistant, and we had only 3 drugs. By the time the BDQ kicked in, it showed then it started showing a good response. As Dr. Alpa was saying, it's probably we need more frequent cultures to detect resistance early. Okay, so I think to begin with, probably we did not start with a good regimen because we did not have the entire DST in place. And secondly, I don't know, this is for Dr. Singla to guide us regarding, whether we should start Delaminid as a drug, replacement drug if we have FQ resistance, or we should consider another drug like an aminoglycoside. Here, Dr. Vijay has started on meropenem, but I would want Dr. Singla's opinion about this. So I think basically we had a weak regimen to start with, and that's why the regimen failed.
Thank you, Dr. Preeti.
Yes, definitely I agree with you on that point that in the beginning, most probably patient was the FQ high dose resistance. So fall and rise phenomena occurred, and that's why initially patient responded, but later on the culture again become negative. Now in the second episode, after 18 months, now we have an opportunity to restart the treatment. So I did not see the LPA report of whether the amikacin was sensitive or not. If amikacin was sensitive, in that case, in this patient, besides other drug, amikacin should have been given. especially when it was sensitive and patient has never received a Mecacin. Number one, even pyrazinamide should have been considered. It's a good sterilizing drug. So pyrazinamide and patient had never received it in the second regimen. Pyrazinamide could have also been considered. And as somebody said, even ethambutol, there is no harm in considering ethambutol also. But definitely amikacin and pyrazinamide along with the other drugs given should have been a good choice in this case. Thank you.
Okay, thank you, Dr. Singla. Coming to next question. The next question was amplification of resistance query for linezolid and BDQ. Dr. Alpa is trying to say something. Dr. Alpa. Dr. Alpa, you're muted.
Yeah. Yes, so as rightly discussed, the reason for bedaquiline, reason for failure of the regimen is that after bedaquiline was stopped, the regimen becomes weak. So all the points discussed by Dr. Preeti and Dr. Singla, I agree with that. The question here is that when we have such a patient whose LPA we don't know and who is a healthcare worker, and he has so about in this patient there was a real false sense of security. One, because the culture did not grow. Second, the lesions were limited. And third, she improved on clinical, radiological, as well as on microbiological front. But in such a patient, because we don't have the LPA report available and the chances of her having a FQ resistance is high, should we not consider giving her bedaquiline extension, waiting for the cultures? Because at that stage, when the patient came to us or patient was referred to us from the periphery, she was already on this regimen. So it's a point of discussion that whether in such case BDQ extension should be considered. Sir, Dr. Singla, sir, your
actually, by the time, thank you, Dr. Alpa, I agree with your comments. By the time patient came again, bedaquiline had been stopped at 6 months. So extension means now you're saying that in the second episode, once we are restarting the treatment, which is different.
No, what I'm saying is, sir, what I'm saying is when you are treating such a patient, not for this, but for other patients also, when we have such a scenario where as a clinician, you have to take a decision after 6 months, whether to stop bedaquiline or no, and you don't have LPA report available, like in this case. So what should we do?
Yes, in the first episode, if you are right, I believe you are talking about the first episode when only refer was raised and LP report was not available. In these cases, definitely the BDQ extension should be considered. So that because we are just giving the drugs in the air, we are not sure about the only thing that in this case, because patient was responding, had minimal lesions, culture was negative, even the follow-up cultures were negative. So the treating physician might have got the false sense of security and the false sense of good improvement with the regimen that my patient is responding, follow-up cultures are negative, X-ray has become better, that they took a call. But ideally speaking, in these cases, the bedaquiline extension should be considered.
And so I want to take this opportunity to point out a very common scene that we see here is that this patient was lucky because her disease was minimal. She didn't have other comorbidities, but we see quite a few number of patients who have got extensive disease to begin with. They have got number of comorbidities. So what happens is in these patients, when we don't give them bedaquiline extension, when rightly they deserve it, somewhere in the continuation phase, very large number of patients do develop linezolid toxicity. Peripheral neuropathy is very common. So one of the drug goes away. And by then already bedaquiline has been stopped, or many times the regimen becomes weak. So we see that these patients, when their failure is not picked up clinically or radiologically, and then by the time the patient come to us at the center, at nodal DRTB center, they have got extensive disease, their general condition has gone bad. Many of these patients even become, respiratory cripple. And in our hospital, at TP hospital, we see a big number of such patients getting hospitalized, and they putting on, they required oxygen support, and they have become very emaciated. And later on, even if we are able to initiate them on a regimen of imipenem, cilastatin, or any other regimen, we are not able to save their respiratory disability. So this is why it is very important at crucial juncture. We all, speed up our mechanisms or get things right, because at ground level, things which happen are very different than what we see on paper, on guidelines.
Yes, and then, yeah, Dr. Abra, I agree with you. Then another question which Dr. Vijay has posed is that bedaquiline did not develop resistance while the linezolid got the resistance report as resistant. So the possibility, of course, is that bedaquiline was given at a time when patient was responding in the beginning of treatment and was stopped at 6 months. So that time bedaquiline was saved. At 6 months it was stopped, and the total number of drugs they were acting. But the linezolid was continued throughout. The fall and rise phenomena occurred. Initially, the sensitive bacteria were killed, and then gradually more and more resistant bacilli were multiplying, and they got the linezolid also to be resistant. So that could be the reason for bedaquiline not being resistant in this case, while linezolid being resistant.
Thank you, Dr. Singla. So coming to the third question, BDQ exposed patients still be treated with bedaquiline based regimen if there is a relapse or reinfection? Dr. Preeti?
Yeah. So I guess the patient has a DST report which says that the patient is sensitive to BDQ. So what we could do is probably redesign a regimen with the existing sensitive drugs and maybe add a couple of more new drugs which are sensitive. But definitely we do not have the sensitivity pattern to, I think I did not see sensitivity pattern to SLID. We did not see sensitive pattern to ethambutol, PZA, and also meropenem, definitely we do not. But BDQ was sensitive, so linezolid was resistant. So linezolid we cannot give. So based on the old sensitive drug sensitivity and a few new drugs, we can design a whole new regimen and start the patient afresh on a BDQ based regimen. So as per studies, BDQ can be extended up to both BDQ and eliminate can be extended safely up to 18 months. So we, despite the patient being on BDQ for 6 months, we still have a good time gap to restart the regimen with BDQ and continue it. So I guess it was a good thing to start with BDQ again and add more drugs to complete a regimen and treat the patient as a failure case as a new patient kind of a thing. As a failure, we are starting the treatment fresh kind of a thing.
Yeah, thank you. Thank you, Dr. Preeti. Yeah, sure, Dr.
Yeah. So the specific question that Dr. Vijay has asked, that can BDQ exposed patient be still treated with BDQ based regimen? This is a scenario when we don't have a BDQ sensitivity available. Okay. So because not every place the BDQ sensitivity may be available, or it may be a time gap before which we will be able to have the bedaquiline sensitivity. So so my answer to this is that yes, bedaquiline, if has been taken properly for 6 months, and after a gap, if there is culture reversion, then many of these patients still retain the sensitivity to bedaquiline, and which is fortunate that we are able to reuse this drug. So yes, we should definitely reuse it. But also there are challenges. So for last 3 years, we have been treating many of these patients in collaboration with MSF and put these patients on the salvage regimen with carbapenems and bedaquiline and delaminate. So what earlier used to happen that before this all longer regimen was available, bedaquiline was not used so commonly. Patients were bedaquiline unexposed. So we used to get much better results. Our conversion rate or the favorable outcome was also tune of 70%. But after having been exposed to bedaquiline, few patients, maybe about 15 to 20% of the patient do develop drug resistance, resistant to bedaquiline. Also, second thing, which is the point to consider here, because bedaquiline sensitivity is not very standardized. So whether can we completely depend on the sensitivity report that is available. And third thing, what happens that now, since all or longer regimen is available, these patients are initially put on bedaquiline. So a lot of time is gone before patients is referred for salvage. So many times, by the time patient come to us, their extensive lung involvement is there. So that also becomes one of the reason for failure. So cavitating disease, extensive lung involvement, that becomes a reason for failure. But the approach that we take in these patients is, yes, of course, we give them bedaquiline, because for making salvage regimen without bedaquiline, again, the regimen would become weak. Sometimes, even if the drug sensitivity is showing that there is resistance with bedaquiline, but we still give them a try of giving bedaquiline again. So this is what is my answer, and I would be keen to know Dr. Singhla's input in this.
Broadly speaking, yes, Dr. Alpha, I agree with you, whatever you have said. So nothing more to be added regarding this particular question.
Yeah,
Thank you.
but there are 3 questions that we can take. Is Sir Dr. Jaikishan sir has asked, can we consider surgery in such cases?
Yes, definitely. In this case, it's a unilateral lesion by and large, and patient has failed to bedaquiline containing longer regimen. So in this case, after doing the CT scan to rule out the extension of the lesion to the other lung, surgery can be considered,
Thank you.
provided facility is available.
Yeah. So now coming to question number 4, treatment.
Oh, sorry, 1 second. In this case, the cavity had disappeared, as I see in the second X-ray. So in case cavity persists, that is a strong indication to go for surgery. In case cavity disappears, the lung lesion becomes very, very minimal. In that case, we can wait and watch.
Thank you, Dr. Singla. So coming to question number 4, treatment regime for previous bedaquiline-based regime failure cases. In continuity of that, there is a question on chat, if the experts can see. What should be the duration of bedaquiline, imipenem, and delaminid in this case, in this when given for the second time? And as clofa, cyclo, and ethionamide will remain after 6 months, out of which clofa and cyclo already taken in previous regime also. So maybe we can start with the discussion on treatment regime. Dr. Preeti, your comment.
Yeah. So as I've said previously, we probably would require to give BDQ and imipenem for even delaminid for longer duration. Because even though we know that BDQ has a, even after stopping the treatment, it is supposed to have a half-life of 5.5 months. But in this case only, we have seen that it has amplified resistance to linezolid. So it would be better that, we kind of extend this and maybe, follow up the patient with cultures. If we see, what I would do is give it for 6 months, extend it by 3 months, keep on doing cultures. And if we see that there are radiological improvement, there is a clinical and radiological and a culture improvement, 3 or 4 subsequent cultures are negative, then maybe at the end of 12 months, 9 months, 12 months, I would stop. Maybe I would still stop the injectable, but then BDQ delaminid maybe still continue, because what we actually have with only with clofa and cyclo, so maybe up to 18 months would still try and see if I can extend BDQ and delaminid, but the injectable, that is the imipenem, I would try and stop it by 12 months depending upon how the patient responds. So it would be a strict follow-up of the patient, see how he responds, and then take the decision.
Thank you, Dr. Preeti. Dr. Alpa, would you like to add something?
Yeah. So here now we have a scenario, it's like do or die situation. Patient has already failed all longer regimen, and the only chance we have to cure this patient is with the current salvage regimen. So in this case, so as we design regimen in this, the first priority is given to the drugs which are not exposed, and DST is showing sensitivity. Second priority is given to drugs which are exposed, but DST is still showing sensitivity. And third priority is that not exposed and not exposed and DST not available. So in this case, patient is not exposed to delaminid and imipenem and cilostazine. So these 2 drugs are included in the regimen, which are likely to work. The third is bedaquiline, which is already exposed, but still the sensitivity is there, and clofa, which is still showing sensitivity. Ethionamide, I think, based on LP of CAT-G sensitivity and not having INHA resistance is not there. So ethionamide is likely to work. So fortunately, we still have 5 drugs available to treat this case. Also, fortunately, the drug is, the lesions are not extensive and patient general condition is good. So in this case, the duration of regimen, imipenem, definitely not less than 6 months. So 6 months is the minimum duration. And since we have other 4 good drugs, maybe at the end of 6 months and patient has already culture converted, we could stop imipenem and cilastatin. But the rest of the drug, including bedaquiline and delaminate, has to be given to the entire duration of 18 months in this case. So this is how we should be treating this patient. Now, sometimes if we are talking of other cases where we are not so lucky, disease is extensive or the resistance pattern is even worse, then we have extended the duration of imipenem cilastatin to 9 months, especially for BDQ exposed patient, and sometimes have gone up to 12 months.
Thank you, Dr. Alpa. There is a question.
Alpa, may I come for a moment?
Yeah, yes, sir, yes.
So somebody asked the question of surgery in this particular case. I'm talking this particular case where the lesions was very less, and it appears that the lesion has disappeared in the X-ray. But such type of cases, CT scan should be done. And if there is a residual lesion where chances of recurrence is there, I think at very appropriate place, the surgery should be thought about. Because a case looks very difficult if you see the resistance pattern and the scenario. So if there is some residual lesion and bacteria will again say multiply and multiply, it will create a problem. So at the earliest opportunity, she must be at least thoroughly assessed for surgery. That is my something to say from my side.
Thank you, sir. Thank you. Dr. Alpa, there's one question for you, that should we be adding pyrazinamide or second line injectable since this patient has not taken?
Yeah, so second line injectable amikacin can be considered now, especially because imipenem cilastatin in programmatic condition is not easily available. Now, also, even if we make it available, challenge is to give it in the field condition. Now here, because we are having this collaboration with MSF and we are able to do it, but it may not be possible everywhere to do it. So amikacin would be a good drug to consider. If we are using imipenem, no, both drugs are not required. But if imipenem option is not there, then amikacin can be considered. But we have to very closely monitor this patient for ototoxicity, especially she's young. So maybe nephrotoxicity is not so much of an issue. But for ototoxicity, we should be monitoring her. Pyrazinamide, I would not be very keen to add because again, we are increasing the pill burden and chances of toxicity. The primary resistance to pyrazinamide also is quite high, to the tune of 40 to 50%. And bedaquiline already has good sterilizing effects. So I don't think pyrazinamide will add anything, by adding pyrazinamide.
You see, on this point regarding the PZA, as per the NDRS survey which was done, among MDR, the PZA DS was registered in about 30% of cases. And these patients who have never used pyrazinamide, and it is quite well tolerated. I think addition of pyrazinamide could help in the second regimen because it has never been used before and the sterilizing action. So I personally feel that PZA can be added in these cases. That's what my
only question here would be, sir, I agree with you, but pyrazinamide and ethionamide together, again, the chances of toxicity, GI toxicity and hepatic toxicity would increase. So whether it would be worthwhile giving pyrazinamide, not knowing the sensitivity, and ethionamide we would prefer because we have the sensitivity and say that INHA is not resistant. So
yeah, this case we can, because culture is available, so we may start, look for the, as you said, PZA and ethionamide together for the LFTs, and ask the laboratory about the PZA DST. The moment it is available, we can revisit the patient and take it off. That can also
in that case, PZA is available, sensitivity is there, then that would be a better drug to use than ethionamide.
Thank you, Dr. Alpa. So would you regime that we are giving currently, would you like to change it, or would you like to, in the beginning, now the patient is responding and has already taken for a few months, should we be giving some other regime right in the beginning of second treatment?
So the only different thing that could have been done, maybe that instead of imipenem, we could have considered amikacin.
Okay. Thank you. So, Dr. Singla, I would request you to, finally give. Dr. Preeti, do you have anything to add? Else, I will. No. Okay. Thank you. So, Dr. Singla, would you summarize the case?
Yes. First of all, very thanks to MSF team and Dr. Vijay from Mumbai.
Nita, before Singla comes, I have one very small query. When the DST came ultimately, what was the status of rifampicin in that particular DST? And then my next question to Rupak. Suppose somebody is rifampicin resistance on gene expert and his DST shows rifampicin resistance. What would be your reaction? Singla.
You see, in this case, sir, I think you wanted to say was that CBNet rif resistance and culture DST rif sensitive.
Yes.
That's what, because you said the.
No. What was the result? I don't know. Whether
Actually,
the rifampicin DST was done or not done, I'm not sure.
I think it was not done, so not informed to us. Dr. Vijay, was it done?
No, sir. Rifampicin sensitivity was not done because when we had an gene expert showing MTB positive and rif resistance detected.
No. What Vijay, I wanted to say that the gene expert is not panacea for 100%. There are limitations even of a gene expert, especially in this young lady who has got basal lesion, very small lesion. So the culture DST actually rifampicin should have been. So that is not the question. Now my question is to Rupak. Is if the gene expert shows say rifampicin resistance and DST shows rifampicin sensitive, what would be your reaction, Rupak? Just I want it from my own self.
Sir, in these cases, as you very well know, in these cases, we should also go for the clinical situation, whether patient is a new case or not, patient has taken treatment before or not, patient has been exposed to the rif resistance case in the family or at the workplace. So these decisions, they also matter because heteroresistance is known.
I know. Yes.
So the disparity.
I agree with you.
Yes, the disparity is not
to me, probably the DST result is more reliable as compared to the gene expert as far as rifampicin resistance is concerned, if it is done properly.
Sir, LPA was done. Second time when the culture came positive, that time LPA was done, which showed CATG resistance, RPOB resistance, and
RPOB resistance. So rifampicin resistance was shown twice. Okay.
Correct. So in the second sample, it will show. Yes.
Right. Okay.
So since we are running now the time is almost, we are running short of time now. So to summarize this case, you see, first of all, whenever a patient, especially who has never taken treatment, is at high risk working as a healthcare worker, based on a single TBNet, we should not start the treatment. We should try to have another sample for TBNet. We can be that should be done. And also we should try to make efforts to increase the yield of sputum positivity simultaneously in these cases so that we can treat the patient better. And in case we have culture positivity, we will have the DST result to the other drugs, and then we can design the regimen or modify the regimen better. And once patient shows in these cases, even the prolongation of BDQ, once we have started the treatment empirical, in these cases, the prolongation of bedaquiline should also be considered. And also keep in mind that sometimes linezolid is not tolerated. Once you are giving for long period, and even if we reduce the dose of linezolid to 300 milligram, that is not tolerated. So in those cases, the continuation phase may become very weak. So keeping that also in mind in such cases where we are working in blind, the initial resistance is important, and also the BDQ extension is important. So these are very important things. And then once patient comes to us again with BDQ failed or there is recurrence of treatment, then again we have to look for whether what drugs patient has taken, what drugs patient has not taken, what is the culture DST result is saying, and whether it is from a reliable lab or not. And combining these two, we have to choose the drugs and then decide about the treatment. And the second episode, definitely extension of especially oral drugs like bedaquiline delamanid should be considered.
Thank
Thank
you. Dr. Sinha, in this case, how long would you like to give the imipinam?
Yes, as already discussed, usually we give it for about 6 months and follow the patient clinically, radiologically, and culture wise. In case all the three are favorable, usually we stop at 6 months because there are logistic challenges, there are cost challenges. We have to give infusion in the morning, 1 hour in the evening. Cost is also too high. We can extend the other oral drugs like bedaquiline delamanid, and we can be stopped at 6 months. In case we find no, it is getting delayed, in that case, 9 months also we can consider.
There's one question: should you be thinking of NTM in such cases?
No, definitely not, because if had it been NTM, the genotypic test like Gene Expert LPA should have been negative. That is positive, so possibility of NTM is very low.
Thank you. Now I would request Dr. Shardul from representing STO Mumbai, STO Maharashtra, to tell us something about what all they are doing in their difficult to treat TB clinic in Maharashtra. Dr. Shardul.
From two device, STDC Maharashtra.
So STDC Maharashtra device, maybe you can connect.
Yeah, given.
Dr. Shah, please join from STDC Maharashtra device. Maybe you try the second one.
Yeah, multiple trying, not this one, then second.
Okay, sorry, Dr. Shardul, we are not able to connect to you for some reason. Thank you. So in this case, in that case, we would like to wind up today. We thank you all for your presence. We are floating the poll. Your feedback is very important to us for improving our next thing. So please take up the poll, and Dr. Bharadwaj sir will now give his closing remarks. Dr. Ashok Bharadwaj, who is chairperson NTM.
So thank you, Nita. Thank you. So I'm sorry because the attendance from medical colleges is very thin. So maybe one of the reason, maybe because we in medical colleges we are engaged in sub-national certification activity for TB-free district in the country. So maybe that may be the reason, and perhaps most of the STF chairman has not joined. So I will not say anything about Dr. Jai Kishan because he is a regular attendee. But most of the others, because I could see the STF Maharashtra, he has joined. So even the attendance 20 is also quite good. But more people should join this endeavor. So I personally was benefited by the discussion, which was a healthy discussion, fruitful discussion, and I must thank you, Nita, Dr. Rupak, Dr. Preeti, Dr. Alpa, Dr. Puri, and Dr. Ajindra Prasad for this healthy discussion, and hope we continue this momentum and this will help solve difficult clinics in the country. So I have also added one thing: when we are doing the review of all STF activities during JTO meeting, I have kept this indicator as one of the indicators how many national clinic STF chairman or their other counterpart have attended. So I hope attendance will increase, and I congratulate your team at NIRT Delhi for continuing the momentum and hope it will continue. Thank you very much.
Thank you, sir. Thank you. The feedback is the link for the feedback is in your chat box. Please fill in the feedback. We've just received 10 feedback so far. Kindly fill in the feed.
Thank you. Good afternoon, Dr. Bharadwaj. लो भैया, आप क्या दिखा रहे हो?
Thank you, Dr. Alpha. Thank you, Dr. Preeti. Thank you, Jaikishan sir, Dr. Puri. Thank you so much. Dr. Rajendra Prasad sir, thank you so much.
Thank you, Baki. Thank you for inviting.
Thank you so much, ma'am. Thank you.
Thank you for the excellent organization, Dr. Meeta, of your team.
Thank you.
Thank you, Singhal sir.
Thank you.
Yeah, Dr. Vijay, well done. Very nicely presented case.
Thank you, ma'am.
Yeah, and you should bring in more difficult cases for us to learn.
Thank you.
Okay, so we are logging off. We are ending the meeting.
Thank you so much, ma'am. Thank you so much.
Thank you, Singla sir. Thank you, all of you. Bye.
Thank you, sir.